In our healthcare world that values biomedical science, technology, and specialization, we often approach diseases, illnesses, or injuries like we would a math problem, objectively and systematically with one solution and one right answer. But we know that these maladies, like the people who have them, don't exist in isolation. People and their diseases exist in relationship with their physical and social environment. They are influenced by their history and their hopes for the future. And how they deal with the challenges that they face is affected by their emotions and beliefs. All of these conditions that impact people and their illnesses and diseases are part of the complex stories of those individuals, and those stories help us better understand the impact these illnesses have on the individual, the family, and the community, and help frame a response or treatment plan that best fits that unique situation. The questions are, how do we get those stories told, and how do we best use what we learn from those stories to help people attain better health? We'll try to answer those questions on today's episode of A Public Health Journal. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to talk about something called narrative medicine or narrative health, where the stories that patients tell help provide insights into the health problems they are experiencing and also help provide clues on how best to help the patient better deal with the problem. Joining me in this discussion is Syl Jones, an award-winning playwright who is using a Bush Foundation Award to study narrative health or narrative medicine and its potential impact on the health of both patients and clinicians. Syl, welcome back to the program.
Thank you, Ed. It's good to be here.
And I always am impressed that most people don't understand that storytelling and theater and drama actually impact health. So it's always nice to have you here to talk a little bit about that. But let's talk about something you're engaged in that's relatively new called narrative medicine. What do we mean by narrative medicine?
Well, there are lots of definitions for narrative medicine. The one that I kind of like is that it's a framework for the way in which a physician or a caregiver practices medicine. That framework is informed by a belief that narratives or stories actually contain the seeds of both illness and wellness. And that part of what we need to do as practitioners is to draw out the stories that our patients may have and to use those stories to help people get better. There's also another side of narrative medicine that has to do with the story of the provider himself or herself and what they bring into the room as they go in to meet their patients. So one of the things we help teach people is to be able to be centered and to be present for that particular patient so that they can receive the story that the patient is going to tell them, provided they practice the medical arts with skill and the kind of acumen that we're talking about, which is narrative competence. So if they do that, they're able to elicit from the patient more information and they're able to be present for that patient's journey of illness. And that's one of the definitions of narrative medicine, narrative health.
Well, I'm a physician, and when I was learning, we had the history and physical exam, and the history it was always said was the most important thing. And so we always said, what brings you to the hospital or to the clinic today? What are your problems? Does narrative medicine get in more than just saying, what's your symptoms? What are the things that you're dealing with? And then listening for that, and then taking that to follow up with the physical exam? Is there more than just saying, what brought you to the clinic today?
Well, there certainly is more, but let's just start with that question. What brought you to the clinic today? There are many different ways you can ask that question. You can ask that question when you're looking at a clip chart and you say, what brings you to the clinic today? Or you can ask it while you're looking away or looking at your watch, which we find more and more physicians are doing based on the kind of time that they generally are allotted to interview patients. So they're not really paying attention. When you say, tell me more about what brings you to the clinic today, I understand that the nurses tell me a few things here. Let me make sure I understand what she said, and then tell me more about that. That's a whole different approach. That says, I'm open to hearing your story. I'm not just here because I have 5 minutes and I've got to rush through our exam time. So it's, first of all, the approach. But then it's the question of how do you understand stories? And most physicians are not literature majors. They don't know how stories are put together. They don't understand necessarily narratology. So the point is that we teach physicians and providers to really understand the stuff of stories, what makes stories vital, what makes them interesting in a medical context. And it's more than simply eliciting the details of the illness that may bring the person to the patient, to the clinic or to the hospital. It may be about what's going on in that person's life, because that may have an impact. And we call a lot of those things the social determinants of health. And we've talked about that many times. The point is that if you don't have time to discuss those things, oftentimes you really miss the true story behind the illness. And that means you might miss the opportunity to actually cure or heal the person, or at least send them on their way toward being cured or healing them.
So it's interesting, and you work at Hennepin County Medical Center. We're doing some of this work, and certainly they have a very diverse population that they serve, different cultures, different backgrounds, economic backgrounds, social backgrounds. Do people tell stories in different ways? Do people from North Minneapolis tell it different than South Minneapolis, or people from Somalia different than people from Nigeria? Do stories, and do the clinicians understand how the story might be coming out from the patient that they're talking with?
Certainly there are cultural differences, and many times the cultural differences are simply the top layer of what makes a story different. Beneath all of that, it may be a history of trauma, which of course is more likely to occur in patients from low income and racially diverse families, or people who are immigrants who are coming to this country for different reasons. Their stories may be informed by shame and by other things that may basically prompt them to edit what it is they tell you. So you may not get the whole story. So what's key then to establishing the relationship with the patient? It's trust. So we also help doctors to learn to talk about their own stories a little bit that will prompt some trust from the patient side. So if a patient comes in and says, you know, I'm having this weird numb feeling in my hands and I'm not really sure what's going on, it's okay to say as a physician, you know, my grandmother had something like that, you know, and I remember that was really disturbing to her. Tell me more about that. What that does is it opens the door to you being a human being rather than a godlike figure as a physician who many people feel inferior to and don't feel like they can relate to. So if you can just say a few things that make people understand that, hey, I'm a human being too. I had that problem, or a friend of mine had that problem. Tell me more about yours. That makes it possible to develop the trust that's so vital to getting the information that you need.
All right. Yeah, this is certainly the art side of the art and science of medicine, and I want to get more into that, but we need to take a little break.
Okay.
We'll be back right after this message.
Hart, what's going on?
I'm leaving.
Why? What did I do?
Not enough. You constantly ignore me. You barely eat anything healthy. You're half as active as you used to be. The pressure is just too much. I quit.
Okay, I get it. I'll do better. Just please, don't leave.
Okay. But remember, if I go, you go.
Listen to your heart. Don't let it quit on you. Uncontrolled high blood pressure could lead to stroke, heart attack, or death. Get yours to a healthy range before it's too late.
Welcome back. We're talking about narrative medicine with Syl Jones, a playwright and a person working in narrative medicine at the Hennepin County Medical Center. Syl, you talked about, you know, that people are stressed for time. They got to get patients in and out in 15 minutes, 20 minutes, whatever the appointment time. How can they do all of this work with narrative, listening to stories? Particularly, some people have long stories and some people have very elaborate stories. How can they fit it into the time period that they have?
Well, you know, narrative training actually helps people to do a better job of listening in a shorter amount of time. It doesn't take more time. It actually takes a shorter amount of time because you know what you're listening for and you know what you're listening to. You also are tuned into the things that might not be there, so you can ask better questions. So this question of time, I know it's a big issue today, and we really are pushing our providers, and we see that with the burnout levels that are going on. But part of what we teach in narrative medicine is that if you connect better with your patients, you're less likely to feel burned out. And Stanford University and some other places that have done research on this show that that's true. Establishing a narrative relationship with your patients helps you have more of an affinity and a bond with your patients, helps you feel better about what you're doing for and with the patient, and also helps the patient feel better. So the time really takes care of itself once you learn the techniques that we teach.
So as I'm hearing this, it's much more than just a passive listening. It's actually an interactive
Absolutely.
thing, proactive.
Very much so.
So you're engaging with that. How do you evaluate how well this is working? I know when we always do evidence-based medicine, and we know that if you get a certain lab value, we can figure out how you follow up on that. If you have certain finding, you can follow up on that, we can evaluate that. How do you evaluate whether or not you're really getting at the true story, or if you're using the narrative to get people to go in a direction where they need to go to understand their disease or illness?
Well, I'll answer that question in a second because it's important about evaluation, but you brought up evidence-based medicine. So narrative-based medicine and evidence-based medicine are not in conflict. They can exist side by side. And really what we're saying is that all of the evidence-based medicine that the physicians and providers learn is really meaningless unless it is applied to an individual. And narrative is about the individual. So it's the application of all those peer-reviewed journal studies that we're all putting in our heads, but applying it to the individual patient. So it's broad-based information that we narrow down to affect the health of one individual, and we can't do that without stories. So the way that this is being measured is there are many articles that are being published today where people at Columbia University and other universities are doing studies to look at what kind of impact does narrative actually have. And what we're seeing is it has, first of all, a huge impact in terms of the residents and interns who are learning this, because they tend to be less burned out and they tend to be more energized. But secondly, patients report better satisfaction. We do patient satisfaction surveys. We know that when patients have a narrative relationship with their doctors and they feel like they can exchange stories and they feel like they can trust their doctors, that they feel better about their health care. Does it mean that they're healthier? We're not sure about that. There's more study that needs to be done on that, but it does mean that they feel better. And if they feel better, that's step one toward actually being better.
All right, and you started out the conversation saying this was not a unilateral kind of thing. You need to know the stories of the providers also.
Yep.
How do you get at those? How are you trying to address the narrative that the clinician brings to this relationship?
Well, for example, in the classes that I teach, one of the things that we start with an exercise about writing basically basically it's a profile of yourself, but seen through the eyes of the patient. So we always talk in medicine about about presentation of the patient. The patient presents in a particular way. The question is, how does the provider present? How do the patients perceive the provider? So we have our providers actually write little essays about how they look when they walk into a room from the point of view of a particular patient. That helps them to reflect on their own self-image and the way in which they show up in a particular room or a particular clinic or hospital. So that's the first thing. The second thing is we ask them to write and to talk about patients who really have affected their desire when they first got into healthcare to be a doctor. So they relate their desire to practice to an actual patient and a patient's experience. And then they share those experiences with their peer group in that classroom. We also do other exercises that are intended to involve their imagination. And imagination is one of the most powerful things that we do in terms of narrative medicine. We get a physician to really think about what might be going on outside the clinic with a patient. And when they do that, they become more fully engaged. So we have different exercises involving music, involving film, also using theater where we can, and then of course literature and poetry that allows the physician to enter a kind of oasis compared to the emergency room or other places where they can really reflect on the meaning of humanity. In other words, how does what they do really impact a human being? And literature tells us a lot about that. There are many poems and stories and illness narratives that tell us a great deal about that. And when we get physicians to look at those things and read them, they really become much more thoughtful human beings and better physicians.
And you had talked about, you mentioned just very briefly the fact that, learn more about the environment that the people, your patients come from. So there's a narrative about communities. Each community has its own narrative, and there's actually multiple narratives. How do you get that? Because we know, when we're talking about the social determinants of health, that individuals don't exist in isolation. They exist in communities, and what's going on in your community impacts your health. It's either supporting or undermining your health. How do you get those kinds of stories at a more macro level into the clinician to be thinking about, to then put the individual story into that broader context?
Well, we use journalism and we use literature to help create that context. So we ask our providers to read stories that really talk about what it might be like to grow up in the barrio of Los Angeles, for example, and to read about the health issues that people who live out there have, and also the social determinants of health that they deal with. We also ask them to become more open to hearing the details that people bring with them as patients when they come in and say, for example, I'm late again. I missed my appointment. I'm 35 minutes late. And they may act like they don't care, but we've asked providers to really think about, why is the patient late, and to have that conversation with them. Because most people don't want to be late to appointments, but there are other things that are making that happen. And sometimes it's very crucial things, not only transportation issues, but issues having to do with relationships, broken relationships, the inability to actually keep time in a way that is congruent with the way we do things in Western society. Those are things that we ask physicians to be open to hearing, and then you have to find adaptations for that. So, for example, in our upstream health innovations work, we are actually tracking patients. We call a cab for them, and when the cab picks them up, using GPS, we're actually able to track them on their way to the clinic. So we know if they're there to get an MRI, they're coming to get an MRI, we know when they're going to arrive. And that really makes it easier for our radiology department to plan. So as we use technology and narratology, we are beginning to put those things together, and we're developing kind of, I think, a new frontier in being able to connect story with all of the different high-tech gadgets that we have today, including cell phone apps and other things.
I want to pursue that a little bit more, but we need to take another little break. We'll be back after this message.
I guess sometimes things just happen. Devastating things. Your whole world changes in an instant. That's what happened to me the day my mother had a stroke. I'm Paul George, and I want you to spot a stroke fast. F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Protect the ones you love. Spot a stroke fast.
Welcome back. We're talking with Syl Jones about narrative medicine. Syl, one of the things that struck me is that we talk about literacy and health literacy, and we're actually talking to clinicians. It sounds like you're talking to clinicians about how to be more literate in terms of the story, listening to the stories and telling their own story. How do we educate patients, individuals, about telling their own story so that they're more literate in telling their stories? Because I don't think people come in saying, I'm going to go there to tell my story. I'm going there to get treated, or I'm going to get diagnosed. Is there something that we can do, generally in our society to improve the literacy level in terms of narrative among the population?
Well, we can do that, of course, and that's important. But let me just say that people, when we interview children, for example, we don't worry about trying to educate them on how to tell their stories. What we worry about is how do we interpret what it is they're telling us and what they're not telling us? So we use combinations of psychology and other things to really look at that. So we hope that patients will learn to be more literate in the Western sense, so that they can tell their stories better. But we also need to be open to different ways of telling stories. And some of the different forms in which stories come to us are revealing in and of themselves. An example is I shadowed a particular physician who was treating a woman who was 21 years old who had gastroparesis. And that woman had had a gastric pacemaker implanted. That woman, during the course of her examination, was asked by the physician, how are things at home? The physician had his stethoscope in his ears and he was listening to the pacer to see if it was working. What he wasn't hearing was her say, oh, I feel so terrible because my mother's living with me again and I feel so sick to my stomach about it. And she wrapped herself up like this, and I watched that. And I asked the doctor, do you think maybe she's telling you that part of her problem is that her mother's living with her? And isn't it unusual in a 21-year-old patient to have gastroparesis and then to have the pacemaker not work? Are we missing the story because we don't necessarily credit the way it's told to us? Mm-hmm. And he had to admit that maybe he was, but he also said, you know, I'm a gastroenterologist and I'm in gastroenterology clinic. And that's what I need to focus on. So the point is that we need to learn to listen differently. It's great about literacy in terms of patients. They need to learn better ways to talk to their physicians. They need to learn better literacy skills, period, just like providers do. Mm-hmm. Because not all of our providers are very literate either when it comes to that.
Well, I mean, that question comes from the literacy, not in terms of, you know, being able to read or write, but the importance of stories. I just remember going with my father to a physician, and the physician was asking questions, and my dad wouldn't share things because, well, he didn't think that that was important. You know, what was going on at home with his, you know, with my mom and you know, her being ill. He didn't think that was important. And so I think part of the literacy is to recognize that these stories are actually really important in setting the tone or setting the stage or setting the scene for the real interaction. That's the kind of literacy I'm thinking about.
Well, that's true. And part of my family, you know, we were careful not to talk to authority figures about things that happened in our family because we were afraid the authority figures would figure that they needed to intervene in our family life. So those are things that actually happen, I think, in the real world too. So again, that speaks to the issue of developing the trust that you really want to develop between the patient and the provider. And that comes over time. That doesn't happen during the first session. But I guarantee you that if you smile, if you look directly at the person, most of the time, if you ask the person, you know, warm and cordial questions and you share something about yourself, you will create an environment that will allow those stories to emerge soon.
How did you get engaged in this? You know, I know you've done a lot of journalism and you've done playwriting. How did you get involved in this kind of clinical setting?
Well, you know that I was involved as a medical reporter for Modern Medicine magazine many years ago. And then the Bush Foundation and we were collaborating around my study of narrative medicine. And I'm going to Columbia University off and on and taking seminars. But I'm really trying to make narrative medicine something more than academic medicine. I'm trying to make it something that's accessible not only for providers but also for patients.
Mm-hmm. So what do you see the future of narrative medicine being? It sounds like this is an evolving field. Is it growing throughout the country?
Well, I think the future parallels the future that we have in healthcare in that we are going to be taking narrative medicine into the community. We need to teach patients not just how to tell their stories, but how to intervene in their own illness narratives. People who are chronically ill, for example, with diabetes, need to know that there's not a big capital D stamped on their forehead that means that they're destined to take insulin for the rest of their lives. They can change their habits, they can change their life story, they can intervene narratively in their stories to make things different. It's about behavior change and believing in yourself, and that's what narrative can do, and I'm working on that right now.
Okay. And are the medical schools interested in this kind of thing?
They are. And more and more medical schools across the country are doing it. But as they do it, what I'm finding is that community centers and other places where health is actually residing, it's in the community, those are the people who really want this and are eager to have it, not necessarily those who are in academic realms. So I think there's a bright future for narrative medicine, and I certainly hope that that there is and that people get involved in it.
Good, great. Syl, thank you for this. It's been really informative.
Thank you very much.
And I'll be back with a closing comment right after this message.
Marie, you have prediabetes.
Prediabetes? I don't have time to eat right or exercise. I'm a busy mom.
Oh, you're a busy mom.
Yeah.
This is great news. Busy moms never get prediabetes.
Wait, what?
Let me just... Yeah, this is all the people at risk for prediabetes, and way over here, busy moms. No?
In her novel Ceremony, Leslie Marmon Silko wrote, "I will tell you something about stories. They aren't just entertainment. Don't be fooled. They are all we have, you see, all we have to fight off illness and death. You don't have anything if you don't have the stories." Now, I've learned in my career that storytelling is one of the most effective ways to learn about and address many of the individual attitudes, beliefs, and behaviors that ultimately affect health. Listening to the stories of patients is incredibly important in the process of creating health. But I've also learned that stories can be used in multiple other ways. Using stories in lectures to health science students about what works and what doesn't with patients with specific diseases or conditions has also been a way to influence the other side of that patient. Be an effective tool in non-clinical situations to influence public policy and public health. Sharing stories with legislators and other policymakers often has a greater impact than our research-based charts and graphs. Stories can help community groups identify with health and social justice issues in their neighborhoods and stimulate action to confront those issues. And stories can be helpful in raising issues and advancing conversations among colleagues when used in newsletters, magazines, and journals. Our technologies and medicines are extremely powerful in treating diseases and injuries, but they are nearly useless in dealing with many of the attitudes, beliefs, and behaviors that play a major role in determining the status of our individual health and the health of our communities. These are influenced more by the everyday experiences with family, friends, community, the media, religious institutions, and schools. Ultimately, stories in various forms may be the only way to modify those influences. Only when we can effectively incorporate our medical expertise with our human stories will we be able to optimally enhance the health of patients and the communities in which they live. I encourage you to become aware of the stories in your life and honor the telling of those stories whenever you can, because in the end, they are all we have to fight off illness and death. In science and society, you don't have anything if you don't have the stories. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.